Good evening to one and all. Wishing you all a happy Ganesh Chaturthi. On behalf of MESAT and API, heartily welcome one and all for this virtual update on diabetes, organized on 7th death anniversary of late Dr. Muralidhar S. Rao, past president of API and RSSDI. I welcome all delegates who have joined virtually from whichever place to learn from the esteemed faculty. I welcome all the office bearers of API and all API members from all over the country who have joined. I welcome our guest of honor, Dr. P.S. Shankar, Professor Emeritus, RGHS Bengaluru. Welcome Dr. Shivraj Alsitti, President MESAT, Dr. Murugesh Pastapur, Chairman API and his team, Dr. K. Govind Babu, Chairman API Karnataka. I welcome Dr. Anand Rao, son of Dr. Muralidhar S. Rao, cardiologist from Mumbai, Leelavati Hospital. I also welcome Dr. Jayant Antani from Pune, a close friend of Dr. M.S. Rao. I welcome Dr. A. Muruganathan, past Governor, ACP India Chapter and past Dean ICP and past President of API. I welcome our today's chief guest, Dr. Jyotirmay Paul, Dean-elect ICP India Chapter, Professor of Medicine from Kolkata, a dynamic personality and active person in API family, held many positions in API, a great academician, chief editor of IMA Journal, with many publications both at national and international levels. I welcome our today's speaker, Professor Dr. Anil Bansali, ex-HOD Department of Endocrinology, PGI Chandigarh, a great academician, researcher, scientist, teacher par excellence, well-known personality in field of endocrinology, both at national and international levels, with many publications and written chapters in books. To deliver this 7th year Dr. Muralidhar S. Rao oration, who readily accepted our invitation. As every year, we conduct this program as a mark of respect to Dr. M.S. Rao's death anniversary, who was dedicated for academics. Earlier orations delivered by Dr. V. Mohan from Chennai, Dr. Prasanna Kumar from Bangalore, Dr. A. Ramachandra from Chennai, Dr. Ajay Kumar from Patna, Dr. Sanjay Kalra from Karnal, but in COVID-19 times, did virtually also Dr. Sarita Bajaj from Prayagraj, Dr. Chandalia from Mumbai, and this year, Dr. Anil Bansali delivering the oration. I also welcome our today's moderator, our own faculty, and a very close associate of Dr. M.S. Rao, whose schedule did not permit him to visit Gulbarga physically for our earlier invite, but joined virtually earlier also. He is a teacher of teachers, doyen in the field of diabetology. No program will be complete without his remarks in the country, both at government and institutions level. A great name in national API, dedicated for academics and policy making in the occasion of the country. I welcome our today's panelist, Dr. Rakesh Sahay, HOD of Endocrine Department of Osmania Medical College, Hyderabad, our own faculty, President-elect RSSDI National, a close associate of Dr. M.S. Rao family, as his father, Dr. B.K. Sahay and Dr. Muralidhar Rao were close friends and worked together in API and RSSDI. I also welcome our other panelist, Dr. Vagesh Iyer, HOD of Endocrine Department, St. John's Medical College Hospital, Bangalore, who had a special affection to late Dr. M.S. Rao, a well-known endocrinologist in Bangalore city and in endocrine society in the country with many publications to his credit. On this occasion, I salute the COVID-19 healthcare workers for rendering their untired service to COVID-19 patients in spite of so many hurdles in the past, anticipating the fourth wave. Let us not waste the time by reading their CV profile, which runs in pages. Let us utilize time by hearing and exchange of knowledge with them in their respective specialty. As many delegates who have joined, who have registered from many states, making a national event. The advantage of virtual meeting, which COVID-19 pandemic has taught a new normal life. Now we have a formal virtual inauguration.
Dipajyotir Parabrahma
we are virtually honoring all our guest faculty for their tremendous contribution to their work done in their respective specialty in the field of the country. Now I request Dr. P.S. Shankar sir to address the gathering.
Dr. Das, Dr. Muruganathan, Dr. Bansali, Dr. Govind Babu, Dr. Antani, Dr. Hai, Dr. Iyer, Dr. Paul, colleagues and friends. 7 years have passed and rolled since the departure of our friend, philosopher and guide, Dr. Muralidhar Rao. We have assembled to hear the oration named after him by Professor Bansali, followed by panel discussion conducted by my good friend, Dr. Das. Gulbarga domiciled Dr. Muruganathan is with us, and I welcome the faculty from different corners of the country. Dr. Muralidhar Rao, the self-made man, his amicable nature attracted large number of people, and he built the multi-specialty Dhanvantari Hospital, and he was the president of Nutana Vidyalaya Society here. He worked with us in MR Medical College. Today, new postgraduates wants a separate unit and want to be independent. During his 3 decades of stay, he did not have a unit of his own. If I tell like that, people will wonder. And he never felt, and all of us worked together without any ill will. He was a good teacher and had training in UK and US. After his return from US, he was interested in the echocardiography and worked on diabetocardiology. He participated in the conference of the API and RSSDI regularly and rose to the post of the president of those organizations. He was the recipient of Karnataka Rajyotsav Award. He was active in all events in the city. The student community adored him, and it was very unfortunate we lost him for a deadly disease which made its appearance all of a sudden. I met him in Mumbai and later Bangalore, and he showed his keenness to be back amidst us, and he was snatched away. His friends and colleagues like Dr. Alchetti, Dr. Sangram have come together to perpetuate his memory, and this academic activity has been organized annually. And many leading luminaries in the field of endocrinology are here online, and we are eager to listen to them. And I wish the program all success. Thank you.
Thank you, sir. Thank you for your kind words of wisdom. Now I request Dr. Muruganathan sir to say a few words.
Thank you, Dr. Sangram. On this memorable occasion of Dr. Muralidhar Rao's death anniversary, I am really happy to connect with all of you. And Muralidhar Rao, as Shankar mentioned, great academician, great teacher. More than that, is a great human being. I had the opportunity to move with him, and I was very close to him. And I'm glad his son is taken on the mantle of his position and then spreading the knowledge. Of course, today is Vinayak Chaturthi day, and the Anil Bansali is giving a talk on paradoxes in diabetes. Even if you see Lord Ganesha, you can learn a lot of things about diabetes by looking at him. He's got the Vinayaka has got a big ears, which means you have to listen always. And then he's got eyes, sharp eyes. You should be inquisitive. And he's sitting under the tree or sitting in the table, which means if you sit, you will get the obesity. So you'll have to go around. And more than that, his head is so big. So you must always keep thinking. And Vinayaka also makes everyone to do lifestyle modification, put Topu Karna in front of him. So I think it is good paradox topic on a paradox God who always makes people to do lifestyle modification, though he likes Kolakata, Elluranda, which is not good for diabetes. So I think on this day, Anil Bansali will have a real rocking topic because he loves this topic. And my good brother Jyotirmay Paul is the chief guest today, and Ashok Kumar Das, whom I just had an opportunity to talk to him day before yesterday and help him. So he's also here. So I'm very happy to connect with all of you. And please, give my regards to the Muralidhar Rao family, and definitely he'll be always in our mind. And as long as the academics, as long as the knowledge, as long as the endocrinology, Muralidhar Rao name will be always here. Thank you, Sangram, for the opportunity. Over to you, Sangram. Thank you.
Thank you, sir. Thank you. Dr. Anand Rao, son of Dr. Muralidhar Rao, is there from the family side. Kindly speak a few words.
Thank you, sir, very much. First of all, wish you a very happy Ganesh Chaturthi. May the Lord give you a lot of happiness and good health in future. And second of all, my salutations to all the teachers on board, which is so good to see all of them. And I'm humbled to be around with them. So my family, including my mother, I think they might have joined, I don't know, but they are very kind of overwhelmed by Dr. Sangram's initiative and the rest of the MISARD members to do this meeting every year. It is, I can't describe how overwhelmed the whole family is. It's really a tribute to my dad, and certain things I like to say a few words about my father whenever I'm on this podium. Apart from being all the good things told by my sir, Dr. Shankar Patil sir, and Dr. Muruganathan sir, and so many others, he's, apart from being a great teacher and academician, he was a great human being. And when I was to work in our clinic, I used to see my father. He never asked for any consultation fees for any patient. He says, whatever is there, just pay it and go outside. I mean, this was the kind of man who was magnanimous in his heart and so compassionate. I've seen him at 11, 12 in the night. He used to go to the patient's house, take them in the car, including so many of my neighbors, take them to Basaveshwara Hospital and make sure, you know, they're comfortable and the treatment is provided to them. All the first aid, everything was done. It was just incredible. I mean, there's so many things to learn from this person. I'm a small ant in this whole ocean, trying to imbibe my father's goodwill and being as ethical as him in the practice. So recently I posted a thing on the Facebook saying, my father used to always tell, "Humne zindagi mein daulat nahi, doston ko kamaya hai." That was his very famous statement. So I believe that, and that's all. Look at this podium. There are so many of them, and paying respect to him. I thank Mr. from my family, my mother, my brothers, my sisters, whose one is Sharmila is in the US, Nirmala is in Bangalore now, Ashwin, Bharti, my mother, and we all are overwhelmed, and we wish this meeting a very, very successful meeting. Thank you one and all for joining.
Thank you, Dr. Anand. Now I request our today's chief guest, Dr. Jyotirmay Paul, for your inaugural address. Over to you, Dr. Jyoti.
Thank you, Dr. Sangram, for inviting me. It is on behalf of Indian College of Physicians, I congratulate API Karnataka branch for conducting oration in name of Professor Muralidhar Rao, who was mentor of all of us who are doing actively API. It is my proud privilege to share the dais in the oration in the name of such a doyen. Professor Rao was not only a past president of API, he was a great teacher, great endocrinologist, diabetologist, and teacher of the teachers. So this proves the greatness of the members of API Karnataka. They did not forget Professor Muralidhar Rao, and every year, consecutive 7 years, conducting such a oration. So I dedicate this oration for the benefit of mankind. Thank you. Over to Dr. Sangram.
Thank you, Dr. Jyoti. Now we move on to the scientific session. Now I request Professor Ashok Das to take over for the further proceedings, sir, as all the faculties are been introduced already. Over to you, Dr. Professor Das. Kindly unmute, sir. Unmute.
I teach my senior leader, Professor Shankar, Professor Biradar, and Vagish. I will not take time because time is very precious. To all of you, my sincere love and greetings. Dr. Muruganathan is a man who has so many talents and so many contacts. I'll tell you what happened when I meet you personally. He was of immense help to all of us. Dear friends, today we have met to listen Professor Muralidhar S. Rao oration from a person who is unique. Dear friends, the orator for the evening is Professor Dr. Anil Bansali. Dear friends, with a very brilliant career from the city of Jaipur, Murli joined in the PGI Chandigarh and rose to the highest academics in a very short time. And you know, his rise was meteorous. I must tell you that he has a command over the entire sphere of endocrinology, diabetes, and metabolism, and his work on various fields, whether it's stem cell transplant, whether it's pituitary, whether it's diabetic foot, whether it is the steroid therapy, everything has given new opportunities. And most important, 2 books of endocrine rounds, which is published, is the main self. I will not speak more about him. I must tell you that this talk is going to deliver today is practice essential. I call it practice essential. It is a very simple but very valuable talk on the paradoxes in diabetes. Dear friends, I present you Professor Dr. Anil Bansali from Chandigarh for giving this oration. Anil, all is yours. Anil?
Yeah. Thank you, sir. Thank you for very, very kind introduction. And thank you, Dr. Sangram, for inviting me for this prestigious oration. I feel honored and privileged. And it was nice to see Dr. Sangram, brother's son here, and who is the witness to the ongoing oration. And it's a great that I have been given this opportunity to deliver this oration before the dawns of diabetes and endocrinology. So I feel pleasure. And what I'm going to present, some of the work in the area which we have done, one. And secondly, this is slightly different from the conventional talks, where there is a more conceptual understanding of the diabetes instead of the monotonous talks. So I'll be talking about the paradoxes in diabetes mellitus. So points to ponder. One is, what are the paradoxes in diagnosis, paradoxes in clinical examination, paradoxes in management, and paradoxes in complications. As far as the diagnosis of diabetes is concerned, the blood glucose levels are still considered as a gold standard. So here you have all 4 criteria are very clearly mentioned, and we are all aware about that. I'll just highlight about the 2 points. One is, if you use a random plasma glucose as a diagnostic tool, then it must be accompanied with symptoms, one. And secondly, it is not 2 hours post-meal. As a diagnostic criteria, it is a 2 hours PPG after 75 grams of anhydrous glucose, and that should be more than 200. The criteria of hemoglobin A1C as a diagnostic tool in making a diagnosis of type 2 diabetes was added way back in 2007. And we have also contribution in this area from Asian population. And the hemoglobin A1C of 6.5% was considered as the cutoff threshold for the diagnosis of type 2 diabetes. So you see that what is the paradox in that? You have what a gold standard is glucose, but the hemoglobin A1C and glucose both are concordant in 53% of patients. That's only half of the patients have a concordance, while the rest 50% they do have a discordance in hemoglobin A1C and glucose values. So your fasting will be more, hemoglobin A1C may be less than 6.5, or vice versa, your fasting will be 126 or less than 126, and hemoglobin A1C will be more than 6.5. So this is the fallacy if you take FPG versus HbA1c consideration. But if you do with the 2-hour PPG and hemoglobin A1C, almost it becomes 1/3. So meaning by that, the PPG further the correlation goes down as opposed to the fasting. So overall, we have got a hemoglobin A1C as a diagnostic tool, and its correlation with blood glucose is only in half of the patients for fasting and 1/3 of the patients with PPG. This is the data from the Italian population, and here again it endorses the same which I mentioned in my previous slide. that 1/3 correlation with 2-hour PPG and half of the patients had a correlation with 1-hour PPG. This is the data from the Asian population from China, and one of the reasons for that why you do this correlation, whether it is anemia, whether it is iron deficiency anemia, or whether it is iron deficiency alone, all are associated with increased hemoglobin A1C or less poor correlation between hemoglobin A1C and glucose, basically because of the low turnover of the RBCs. So that will be one of the reasons for having a discordance in hemoglobin A1C and the glucose values. If you go further, the data from our study, that was a 2,072 patients, healthy individuals, not the patients, where we did a community survey and we found at a 6.5%, the glucose GGT as a gold standard correlated only with 65% of the patients. So here it includes the data for both, that is for fasting as well as the PP. So while in 1/3 of the patients, the hemoglobin A1C did not match with the glucose values. So there was a discordance. However, it had a very high specificity. It means those who were found to have a hemoglobin A1C of 6.5, 88% had a glucose values in abnormal range. So hemoglobin A1C has a certain limitations, and this is the possible explanations for the if the diabetes is of recent onset, you may not have a correlation. Coexisting anemias and iron deficiency can also contribute. Hemoglobinopathies many times goes unrecognized, may be contributory. And another entity called as a slow and fast glycators. Some people like Asian population, they are fast glycators as opposed to the Caucasian who are slow glycators. And aging also itself is a risk factor for slow deglycation. There's three terms: glycation, fast, and slow. And there's another term called a deglycation. So aging is associated with a low or slow deglycation. And this is our data with the aging, where we published in Chandigarh Urban Diabetes Study, where you can see that the people who are above 70 years of age, of course, the number is bigger, small, 65 only, but they already had a hemoglobin A1C in the pre-diabetic range, while the glucose values were absolutely in the normal range. So with the aging also, the hemoglobin A1C rises, and it is possibly because of the slow deglycation of the glycated globin. So one has to understand this paradox of hemoglobin A1C and glucose values. So the glucose value still remains gold standard. However, the value which you find in clinical practice, which is abnormal, say fasting is less than 126 and your hemoglobin A1C is more than 6.5, you repeat the abnormal value. So repeat hemoglobin A1C in that scenario, and that should come from that. So now let us see the paradoxes in clinical examination. So this is you are seeing for that the two phases of insulin resistance. One is an obese individual having a severe acanthosis nigricans. Almost it's a grade 4. The hair is a necklace of the this black velvety pigmentation. While on the other side you see it's a feature of the severe insulin resistance as a part of facial lipodystrophy. So you can see that there are two phases of insulin resistance as a part of the clinical paradox. Similarly, we described an entity called the diabetes hand, like we have a diabetic foot. So we worked on diabetic hand and we showed that Dupuytren contractures, which is a common in chronic liver disease, is also not uncommon in diabetes. And the pattern of this tendon thickening was more prevalent in vertical fashion in patients with diabetes as opposed to the horizontal fashion in patients with chronic liver disease. The other paradox in clinical examination, many times you find the dorsalis pedis is absent, patient is having a diabetic foot ulcer, so you have a dysphoria because of the ischemic ulcer. If the pulse may be bounding and patient is still having a DFU, diabetic foot ulcer, the probabilities are Charcot's, neuropathic ulcer, small vessel disease, infective head arthritis, and Monckeberg medial sclerosis. And if the pulse is absent, DFU is also absent, then coexisting collaterals or normal aberration in 10% of individuals. Next. Yeah. Yeah, I think. Then, okay, if there's a weight regain. So now we talk about the paradoxes in therapeutic aspects. the weight regain despite continued lifestyle modifications. We find many times that patients who are continuing doing a lifestyle modification program, they are adapted to that, but they do have a regain in weight. This is what we have called as a yo-yo phenomenon. And the explanation for this yo-yo phenomenon is, next is, yes, so these are the adaptive changes in adipocytes following weight loss. Once the fat is released from the adipocytes, they become more stressed. And the stressed adipocytes are secreting more pro-inflammatory cytokines, which leads to more immune responses, more energy uptake, and decrease in energy expenditure. Another contributory factor for when the fatty acids are decreased in plasma, then again the energy expenditure is decreased. The decrease in lipolysis leads to increased capacity for glucose and fatty acid uptake because the fat cells are now starving. So it's a modulation into the stress adipocytes. After losing the fat, they become more hungry. So whatever you eat, it gets deposited along with your energy expenditure is reduced. So that's the explanation for that, why even someone continuing with the same quantum of exercise, still they do experience no loss of weight in clinical practice. Next. Then another conceptual understanding, we always talk about the weight gain in type 2 diabetes. Is it healthy? Let us see that. It is never. You see the fat topography in patients with type 2 diabetes, you have fat everywhere. You have a plasma-free fatty acids, muscle fat called as a marbleization of muscle. You have a hepatic fat, you have an arterial fat, you have a subacute fat, you have an intra-abdominal fat, and you have a pancreatic fat. And remember, this pancreatic fat is very important, and this pancreatic fat is responsible for beta cell apoptosis. And I will share you one information is that in a direct study, when they look for the ectopic fat in the pancreas, if you lose a 15 kg body weight, you lose only 1 gram of the fat from the pancreas. And that even losing a 1 gram fat from the pancreas is responsible for the reversal of diabetes. So you can see that how this pancreatic fat, only 1 gram, because islet weight is, if you talk about the weight of the pancreas, is something around 120 to 150 gram. And islet contributes only less than 1% of the total cell. So hardly the pancreas, endocrine pancreas weight is around 3 to 5 gram, and only 1 gram is fat. So if this 1 gram fat is removed, then you have got an improvement in beta cell function. So let us see that this was a very, very illustrating dialogue came when the SGLT2 inhibitors were introduced. The CV morbidity and mortality increases. The A1C goes down. It is invariably associated with weight gain. But there is a paradox that even you gain weight, despite the cardiovascular mortality goes down. Next, please. So this is the average weight gain with most of the anti-diabetic medications. And you can see that I think everyone is aware of that. So there's no need to read, but the pioglitazone and glibenclamide both are very notorious, which I think the people are not using much. And now the SGLT2 inhibitors, they lose around 2 to 3, 3 to 4 kg weight. And GLP-1, 3 to 4 kg, and your semaglutide is something around 5 kg weight. Next, please. Is weight gain is detrimental? Yes. The average weight gain of 1.7 kg in most of the studies has led to the increase in a risk of heart failure. So many trials, I think, shows very clearly that the weight gain is detrimental for cardiovascular events. And this is further endorsed by, next, this is further endorsed by the Swedish National Diabetes Study, and that showed that there is an increase in total mortality by 27% if there is a 5-unit increase in BMI. So weight gain overall is harmful. That's why the more focus has gone on the anti-diabetic medications, which causes a weight loss. Next, please. So, but only one study that is a proactive, the one factor which predicted that participants would not die. What is that factor? That was the weight gain. So those who gained weight with pioglitazone in a proactive study, they had a longer survival. Let us see why they had. So you have got a change in a topography of the fat with pioglitazone. Your pancreatic fat goes down, arterial fat goes down, liver fat goes down, visceral fat goes down, everywhere. So weight gain with thiazolidine is healthy. This is, I am not saying that you prescribe pioglitazone, but for a conceptual understanding, the weight gain sometimes in patients with type 2 diabetes with this class of a drug is not harmful. Next, please. So this is again our data of pioglitazone and metformin on adipocytomas. You can see that the pioglitazone, there is an increase in adiponectin and there was no change in leptin. While on the other side with the metformin, you have a decrease in leptin but no change in adiponectin. So that's why the pioglitazone is associated with a very important pro-vasoactive cytokines, that is adiponectin. Next, please. Then another paradox, we use insulin in insulin-resistant state. Everyone will ask, type 2 diabetes is insulin-resistant state, and why we are using insulin in insulin-resistant state. Next, please. This can be explained by the dose-response curve. One has to understand, if you see that the total glucose uptake in healthy individuals versus in type 2 diabetes, at any insulin concentration is lower as opposed to healthy controls. We can overcome this response by increasing the doses of insulin. If we increase the doses of insulin, then the maximum response remains same, but the curve is shifted to the right. So that means that we can achieve the same response by increasing the doses of insulin in a patients who are insulin resistant. And you will remember that at a given time, only 10% of the insulin receptors are occupied. 90% of the insulin receptors are unoccupied. They are called as spare receptors. So by giving the additional doses of insulin, you are covering those spare receptors and causing the curve to the shift to the right. So that leads to improvement in glucose profile. So that's the explanation for that. The using insulin is helpful even in insulin resistant state because the dose response curve is shifted to right. Then another drug which came into the very limelight that gives an opportunity to understand that all the vasculoprotective anti-diabetic drugs are always cardioprotective. What I mean by that, some drugs may be coronary protective, while some drugs may be the cardiac myocytes protective. So we have segregated this difference by analyzing the data of a GLP-1 receptor agonist as well as the SGLT2 inhibitors. Let us see, next please. So this is the data with cardiovascular outcomes. And if you look for a 3-point MACE, so from a placebo, it is definitely non-inferior, but otherwise it is not superior. So what do you mean by that? There was a 14% reduction in primary endpoint. Next, please. But if you look for a heart failure, then there was a 33% reduction in heart failure with hospitalization, which was significant. So you can see that SGLT2 inhibitors are more having an effect on cardiac myocytes as opposed to the coronary vasculature. If you look for a GLP-1 receptor agonistic analogs, they do have a significant effect on 3-point MACE. There was a 13% reduction in MACE that was statistically significant. So even for a superiority, you find p-value is significant here. But if you look for a hospitalization for a heart failure with GLP-1, next please, then you are not finding for the significant benefit. So you have got some difference in SGLT2 and GLP-1 agonistic analogs. GLP-1 are having a more protective effect on coronary vasculature, while SGLT2 inhibitors having a more protective effect on cardiac myocytes. And another drug, again the pioglitazone, I will talk about that because this drug, if you talk about the 3-point MACE, death, MI or stroke, it is the beneficial. You can see that. But on a cardiovascular outcome, again, this shows it is a beneficial. Next. And even in stroke, the pioglitazone surprisingly did very well. So even on a cerebral vasculature, there was a 47% risk reduction for the stroke. So meaning by that, the pioglitazone is a vasculoprotective. Next, please. and this is attributed to reduction in adenoma volume. Next, please. But if we talk about the cardiac myocytes, it is detrimental. So again, you can say that, so pioglitazone is more or less behaving like on a very bad on the myocytes, but good on the vasculature. So this is a summary of these cardiovascular benefits of these three classes of the drugs. And you can see that the 3-point MACE, pioglitazone, does very well. SGLT2, okay, does well. While on a heart failure, the SGLT2 dominates. Next, please. Another paradox which we see is declining EGFR, yet renal protection. So let us see that. The decline in EGFR, it happens with the ACE and ARBs use, which we already discussed. But now in the current era, the SGLT2 inhibitors are very, very important. And you can see that on the placebo, the EGFR progressively declines, while with the SGLT2 inhibitors, initially there is a decline followed by the plateau. And so this plateau is useful because overall in a 6-year follow-up, you are having a beneficial effect on renal protection. This is further endorsed and supported by next, that your regression of albuminuria and progression of albuminuria goes on, while the progression of albuminuria is stopped. So that's again in favor of that. And the mechanism for that, how these SGLT2 inhibitors causes the renal protection. And one of the next is the predominant mechanism is it lowers intraglomerular pressure by restoration of the tubuloglomerular feedback. So what is a TG feedback? In a TG feedback, the sodium from the proximal convoluted tubule its reabsorption is inhibited by the class of the drug SGLT2, which increases the delivery of the sodium to the macula densa. This increased delivery of the sodium to the macula densa leads to release of a substance called as adenosine. This adenosine leads to constriction of the afferent arteriole and reduces the intraglomerular pressure. So this is one of the very important mechanism for that. And your ARBs and ACE inhibitors act on efferent, they act on efferent. So efferent arterial dilatation is associated with reduction, and afferent arterial constriction is associated with reduction in intraglomerular pressure. So that's why the SGLT2 and the ACE or ARBs, they are complementary to each other. Then one will be very much surprised that you have an intensive treatment of diabetes, but still you have a worsening of complications. So let us see what are the complications which get worsened with insulin therapy. So this is the data with DCCT, and very clearly showed there's a worsening of the diabetic retinopathy in a first year, and later on it becomes stable. The reason for worsening is the glucose is a vasodilator, and once the glucose is lowered down, then the vasodilatory effect of the glucose is lost. So there's eventually retinal hypoxia. Another reason being an intensive insulin therapy leads to more IGF-1 generation, which leads to angiogenesis. And also the intensive insulin therapy has got an effect on basement membrane of the retinal capillaries, that is on MMP, matrix metalloproteases. So their breakdown is there, which eventually leads to worsening of retinopathy. However, with time, it is an improvement. Next, please, the other complications which worsens with that, worsening of retinopathy with liraglutide have also been reported. Worsening of neuropathy have been reported with intensive insulin therapy. Next, please. The anti-diabetic drugs we use in non-diabetic states. Next is, so non-diabetic uses of anti-diabetic drugs, you can see that PCOD use metformin and PIO. In a NASH, you use a PIO, metformin, and SGLT2. In a heart failure, even in a non-diabetic use by the DAPA heart failure and other studies, the SGLT2, obesity use, CKD use, lipodystrophy, and now the new indications for an SGLT2 inhibitor recently was SIADH, where it improves the serum sodium concentration. So these are the pleiotropic effects. This is one of the work on steatohepatitis NASH, and this was the effect of pioglitazone which leads to change in both stenosis score and change in liver injury score. So this is our small data on NASH with metformin. And metformin has not been found to be so comfortable with the improvement in the NASH profile. However, the ALT enzymes, those who are resistant to that, they did very well response to metformin, and there was a decrease in the ALT with the use of metformin. So to conclude, the paradoxes in diabetes are encountered in day-to-day practice and diagnosis, clinical examinations, and management. I think physicians should be aware about these oddities to avoid errors, one. And secondly, this talk gives an insight into the conceptual understanding of some of the oddities in diabetes. Thank you. Thank you so much for patience hearing.
Anil, it was a very practical talk, and it spread out. You touched upon many things which will highlight few things during the panel discussion. It was very practical. It was a lot of take-home messages, and I liked your ideas regarding pioglitazone, and we did a program with Diffronjo last week, and pioglitazone is poised to come back. Pioglitazone and lobeglitazone, which is a congener of pioglitazone, is coming back in a big way. And I like the idea that it decreases stroke by 47%, which is real fact. And non other drugs which have come today, SGLT2, there is effect on the stroke, but not 47%. Your ideas regarding the diagnosis will take up during the panel discussion. We highlighted about the KGA1 paradox, which is a great thing. I mean, you talked on various aspects of the day-to-day management diabetes mellitus, about the various issues. We encountered that in the beginning of the control, there is a apparent or there's a real worsening of the complication. But at the second year, am I correct, Anil? At the end of second year, the worsening that we find in the first year of tight control or therapy gets neutralized. Am I correct? That was shown not only in this city
Later it improves, yeah.
retinopathy, it was also shown in the Paris trial, Hivider trial, all the trials. And it was also shown partly in SUSTAIN 6. There's a retinopathy was in the beginning, which is improved, but that has to be improved in larger population. Thank you very much for giving the practical knowledge. A big hand of applause for Dr. Anil. Anil, please stay with us because we'll be having not later than 7:55. We'll call it a day by 7:55. Please stay with us. And because we have two very eminent panelists. One is Professor Rakesh Sahay, the sitting president of the ESI, and he is the son of Professor B.K. Sahay, a very close friend of Professor Muralidhar S. Rao, and I met for the first time Professor Muralidhar S. Rao with Professor B.K. Sahay, inseparable friends. And we have another don in the field of diabetology and endocrinology, Dr. Wagesh Iyer from the St. John's professor. He had just left the headship, and he is the full professor, and has contributed immensely in various aspects. Dear friends, we have 30 minutes, so we will be very brief. So I request the panelists to give very brief answers. I'll be asking one or two questions to others also, just to break the monotony. I will start with the HbA1c, which Dr. Anil first alluded to. I've also, me and Dr. Sangram Biradar both have requested people to put the questions in the chat box. And so we will pick up the questions from the chat box first. Recently, there is an increased incidence of diabetic retinopathy, and it's from Sangamesh Ajodhya. There's an increase in syllabic nephropathy. What are the reasons, sir, for the increase in nephropathy? So I'll direct the question to Rakesh first. Rakesh?
Yes, sir. Sir, thank you, sir. I think at the outset I should I should applaud the efforts made by Dr. Sangram for organizing this oration year after year, and he has been doing this he has been doing it very regularly, and the MISART and API Karnataka for doing this oration. Dr. Muralidhar Rao, as you have rightly mentioned, was a very good friend of my father, and they were actually classmates in the medical college. And because Dr. Muralidhar Rao studied in Hyderabad, and then he moved to Gulbarga and settled in Gulbarga. So I think that's the reason why they were very, very close. They were very close all through, and I also had the opportunity of being with Dr. Muralidhar on many occasions. So coming back to the oration, I think I should, Dr. Bansali sir, as usual, as in his unique style, has brought out so many different paradoxes in diabetes, which are very practical, for day-to-day management of diabetes. So with those few words, I would come back to the question that you have said, that there is an increased incidence of diabetic nephropathy in the recent years. So basically, I would like to say that one important thing that we should understand is that with the availability of a EGFR calculator, we are more often, now routinely calculating EGFR, and we are able to assess that, and we are able to sort of understand that many times when the creatinine has just gone up by from 0.7 to 0.8, we find that the EGFR has dropped by 15 to 20 ml per minute, and with the availability of the staging that is done, with the recognition of that. So I think those are, one of the important reasons why we are picking up nephropathy more. Early we are more aware about nephropathy. Earlier days, probably, we used to look at only a creatinine of 1.4. If it crosses 1.4, then we were wary about, we were alert to avoiding the use of certain drugs. So that was the only thing that we used to do earlier. But now with the availability of this EGFR calculator, it makes it easy for many of us to recognize nephropathy early. So I think that is one important reason why we are seeing a higher prevalence. And it is good that we are identifying it early, because we are able to adopt preventive measures earlier, and we are able to prevent the progression. How much we are doing that is something which we always need to work more on any parameter that we are doing. But I think the recognition is important, early recognition is important, and I think that is one of the major reasons, I would say.
I think you're absolutely correct, Rakesh. KDIGO recently gave a paper in which said there are three regions, as you rightly said. Whether the numbers are increasing really with percentage wise is a different issue. But number one, the diabetes per se has become very widely prevalent. So the ESRD in diabetes also has become very prevalent. Second reason, it says that many of these diabetics are living longer. And when you live longer, the chronic kidney disease complication becomes becomes quite evident. So there is apparent increase or real increase in the number.
May I add to it?
Yes, just 1 minute, Anil. The third thing, I'm quoting from the JCM paper in the 2014, Anil. You might have seen that paper. The third thing, it says that, apart from diabetes being more prevalent, the diagnosis being, as you rightly said, being more common, Rakesh. Third thing is that they're more and more accepted for the ESRD program, whether it is transplant, whether it is hemodialysis program. So when they become apparent, the number still increases. So yes, over to Anil.
Yeah, so I would like to add an additional point is that diabetic complications is an outcome of increasing longevity. So now the patients with diabetes, they are living longer. They earlier used to die because of the cardiovascular events, but because of revascularization procedures, they are surviving. So they have already crossed the one major hurdle, that is a cardiovascular disease. And if you live longer, then certainly you are likely to develop poor complications.
Yeah,
I think that's one of the very important reasons. Another reason is for increasing prevalence of a disease that is also happening because we have a very large pool of people with pre-diabetes who are getting a faster conversion to diabetes. And lastly, what the Dr. Sai added is the facilities. You have an estimation of the EGFR by the app, and even the facilities for AC ratio is available now at most of the places. So it is done. So that is also gives a early recognition and early pickup of these patients.
So Dr. Sangames, you have got your answer, and Dr. Anil added a very beautiful thing, the concept of cardiorenal syndrome. We say the diabetic kidney disease is a disease on which heart attacks occur. The other way also it is true, and Anil rightly pointed out, they also kidney disease. So I personally believe the kidney disease in diabetic is poised to become a big problem like cardiac disease. And I think coming years will show, what do you feel, Vagesh, will show that the kidney disease is definitely important. There's another question which I'll ask you, Vagesh, you can answer the first question also. This is asked by, again, I'm very happy, Sangramji, that we have so many questions. It's about ketogenic diet. Whether ketogenic diet is beneficial in type 2 diabetes mellitus, and whether it is safe to advise in diabetics, whether it can precipitate decay. There are three things, 3 in 1 question. Whether ketogenic diet beneficial in type 2 diabetes. Number 2, is it safe to advise the diabetics this diet? Number 3, can it precipitate decay? The questioner is Shivaling Nisti.
Thank you, sir. At the outset, I'd like to thank all the organizers, especially Dr. Sangram Biradar. And I shared a very close relation with Dr. Muralidhar Rao. In fact, he had invited for the CMEs in Gulbarga. That's how I got connected with even Dr. Anand. Dr. Pinto, Dr. Anand, we ourselves were in Gulbarga. It's a pleasure to be here in the among eminent panelists, including Bansali sir. He's teacher for everyone who is here. So regarding regarding ketogenic diet, when you take a numerical value of a decrease in the glucose value, yes, it may reduce. But what it creates is, in fact, we have seen whenever there is lots of fat taken instead of the protein and carbohydrate, your arteries are flooded with the cholesterol, free fatty acids, and other things. In fact, what damage it does to coronary arteries is less often studied. One of the outcome of a ketogenic diet, some studies, some unequivocal or even anecdotal reports have said that increase in the CAD. I think best example is one of the past president of America. He went a ketogenic diet, he lost the weight, subsequently has to undergo a CABG. That was the effect. So whatever we know about ketogenic diet is for a short period of 6 months or a little more than that, but long-term outcomes have not done. But there is some impact beyond glucose control, that is impact on the vascular studies, which has not seen. Then the question comes, is it safe to advise? I think only a long-term study will show that it is safe or not in a diabetic patient. Short-term studies have shown improvement in the glycemic control and a weight loss. Can it precipitate a DKA? In a type 2, probably no. Type 1, don't try this one.
I think very short but very brief answer, which is very far-reaching consequence. I know all of you know him. His name was cited some time back, who went on a keto diet. He developed Anil, very severe RI fibrinosis. For 1 year, he had to take vitamins. He developed that. I think ketogenic diets are good. It can produce low-carb diet and it can take control of diabetes, make it easier. But its effect on the kidneys and coronary artery disease yet to be established. So I'll stop the discussion there. I want to ask
one comment. Can I?
A very, very brief comment.
Yes, sir.
Can I make?
Yeah, brief comment, Anil.
Yeah. So my comment is that Vagesh very correctly pointed out that the ketones are in fact the preferred meal for heart and brain. So it's a feast for the heart and brain, in fact. But here you in a keto diet, you are off carb mainly and you are compensating it by more fat and proteins. So they're compensating it by more fat-rich diet and particularly more saturated fat in that way. That's why you have more cardiovascular events. So I think the balance of that's why the intermittent concept of the intermittent fasting that came. So where you have a very mild ketosis, which is not detrimental, where the calories are restricted in a form of a time TRE, that is a time restricted energy intake. So that helps in weight loss as well as a good glycemic control. But on an extreme restriction of a carbohydrate eventually leads to weight loss, no doubt, but leads to more cardiovascular events, partly because of the more pro-inflammatory cytokines as well as the more fat consumption. I think that one has to understand.
Yeah.
Despite the ketones being a preferential food for the both heart and brain.
Yeah, I think.
Just to add one point, sir.
Yeah,
I mean,
please,
yes, sir. You have already mentioned about that, but there have been several patients I have seen whose creatinine has gone up with the keto diet, and there was a reversible increase in the creatinine levels with the keto diet, and that was clearly seen in many patients that I've seen. So I think as sir has highlighted, Dr. Bansali sir and Dr. Vagesh have highlighted, I think that's not the best diet, and I think if you're looking at weight reduction, then I think low calorie restriction is the best thing which has been shown over several studies. That's my personal.
I think Rakesh, you're absolutely prophetically correct. I just read out the latest paper that we wrote. It's a very important question Dr. Nisti has asked. High in fat and high in protein and low in carbohydrate, that is a ketogenic diet, as Vagesh beautifully described, they have the potential to exacerbate, Rakesh, as you know, acidosis, metabolic acidosis. At the same time, higher protein ketogenic diet hastens possibly kidney failure. You know, one of the ways in armamentarium in diabetic kidney disease respect protein. Are you getting my point? So it has been opined. I'm reading a paper from the again JCM. It can hasten the kidney failure, and number two, and cause the medical patterns which are high, as pointed out by Dr. Rakesh, high in urea, creatinine, and non-protein nitrogen. So therefore, it is possibly not good for the kidneys. There's a separate paper which has been going round and has maximum number of hits. It says the potential dangers of ketogenic diet on the diabetic kidney, and exactly what you, Rakesh, and Anil has discussed. Everything is there. Honestly, thank you very much for asking that question. Now, before I go back to chat box, there is one more question. I can ask to everybody one important question to both the speakers, one by one. You know, we started with the HbA1c. Now, what is the role of HbA1c in the era of TIR? Rakesh?
Sir, I think while TIR gives us very important information, but HbA1c still has its very important place, because we have immense amount of data which has shown the correlation of the various complications with HbA1c. So we still continue to use the HbA1c. It will always be used. The only thing is that TIR gives us a better information when there is a wide fluctuation which is happening in the blood glucose levels, particularly for a short period of time. For adjustment of therapy, that becomes a very useful tool, and that helps us in adjusting therapy and using therapies which have which provide a better sort of control, glycemic control. But HbA1c is an important tool which is very important for long-term glycemic
very important. You see, our treatment, short-term treatment, daily treatment can depend upon TIR, but long-term treatment is on HbA1c. Absolutely prophetic answer. I will ask you something, Vagesh, which Rakesh hinted at. Now, what is the impact of this glycemic variability, which Rakesh referred to in the advocate TIR, glycemic variability on the diabetic complications, Vagesh?
Yeah, I think it is one of the fourth pillar. We know that fasting, postprandial, A1C are the three pillars of the control. The fourth pillar in the control and the complication is the glycemic variability. It has been found that if somebody who has got a HbA1c of a 7, but he has got a glycemic variability, he loses the benefit of reduction in 1% of HbA1c, means equivalent to having 8 rather than a 7. And it has been very well established, both micro and also macrovascular complications have been linked to the glycemic variability. And this variability increases as the A1C worsens. So that's also important. That's why A1C is like our annual result. Your glycemic variability and the TIR, your monthly tests.
Absolutely, absolutely. Now,
Can I make?
Yeah, yes. Anil, most welcome. Very brief.
I think one of the important implications of a hemoglobin A1c and a target in range is that many times you find in a clinical practice that a patient is continuously maintaining or consistently maintaining a hemoglobin A1c below 7. And despite they do have a progression of complications, not only cardiovascular, but particularly microangiopathy. So even the proteinuria may exceed the limits, or even the retinopathy may worsen. So in that scenario, I think that even hemoglobin A1c may be normal, then the TIR will become very important. So the suspicion of so you can further go into the intricacies of a diabetic complication when you're finding the hemoglobin A1c is below the target or in the target range, but your complications are rising. And I think one of the major reasons for that, why we are having a glycemic variability. So this is mainly because this happens mainly in patients with type 1 diabetes who have absolute insulin deficiency. So it's an impaired crosstalk between alpha cell and beta cell, which eventually leads to glycemic variability. So I think this is happening in a patients with type 1, no doubt, but this also happens in a patients with type 2 diabetes with advanced duration of disease. This sometimes you find even in patients, those are maintaining a hemoglobin A1c below 7, but still their glucose values may not be target in range. So this happens that once the beta cells are recovering from the glucotoxicity, then again you may have variability, but eventually it settles down. So it's an impaired crosstalk between both alpha and beta cell, which
Absolutely
leads
correct.
to, and then the concurrent GLP-1 deficiency, that leads to worsening of the glycemic variability.
I have another question to ask to both Rakesh and Vagish. Rakesh, for the benefit of the huge audience that have joined, I read one of the interviews of Professor Muralidhar S. Rao. He became the president of the API from Gulbarga, and he was the second person from Karnataka to become the president. And there was a huge applause in 2000, if I remember correctly, 2011. And he had given an interview to one of the doctors, who was published, and it's a highly quoted interview. There he says, "I'm very passionate about the monitoring of diabetes." So I would like to know, Vagish and Rakesh, both of you are very eminent. Of course, I'll ask Anil also. What is your opinion? The flash glucose monitoring, the CGMS is of course there, but it's not in reach, Anil, for everybody. What's your comment about the SMPG first, but very brief comment because I have only 20 minutes more. And second, your comments on the connected meters. I'll come to Vagish first and then Rakesh next. Professor Muralidhar was very, very passionate about the diabetes monitoring. Yes.
Yeah. I think whenever we initiate a treatment, the initiation is a half done if we don't monitor the patient, both on a day-to-day or a weekly or even a more frequently based on the patient's type of a patient we see. For example, type 1, we want at least 4 readings per day, and the patients who have got a GDM, we want at least 6 to 7 based on the patient's motivation and also what type of a complications he have got. That's why most societies have come out with at least a recommendation which may not be a level A, at least level E in most of the recommendation, but monitoring is very, very important. But what has added to the monitoring is a cost of the therapy. In fact, many a time the cost of the monitoring becomes much, much more than the therapy we are giving. That's why we are facing a problem and also acceptability by wide population. But in a motivated patients, it's very, very useful. In fact, I have got some of the very motivated type 1 patients. They are maintaining HbA1c of 5.7. And they are monitoring not 4 times, they are monitoring 7 to 8 times. Even when they take a snack, they check their values and they correct their glucose level. But this pricking frequency has been reduced by using our FCMs flash, so that just they can pass their Android phone across the sensor and they know the values and they can use. I think that has been a greatest advantage move forward with the advent of the technology, but it comes with a cost. I think that we have to keep in mind.
Rakesh, very brief answer.
Yeah, so I think Vagesh has very rightly brought out the importance of monitoring in terms of maintaining good glycemic control. And many a times, I mean, what we find is that people are not in control because they are not able to monitor regularly. The monitoring actually gives them a good feedback because many times they can themselves understand the changes that they need to do in their lifestyle, in the food that they eat and all that with the regular monitoring.
Correct.
And I think the connected meters, I think I just want to add a little bit. Rakesh has highlighted the importance of flash glucose monitoring, where it makes it very convenient for patients, but again it comes at a cost. So now when you're looking at the glucometer, self-glucose monitoring, self-monitoring of blood glucose by the glucometer, they have become actually much more affordable for most of our patients. In fact, the cost of glucometers has gone down quite significantly, and the cost of the strips has also come down quite significantly. And I think that is the one which can be done on a longer term basis by the patients. They can maintain that on a longer term basis, and the connected meters actually makes it better, because many times we have patients who come, just they casually look at their glucose levels but don't respond to that at all. They don't take any action on that. If they're not taking any action, there's no point doing it, because they just tell you a few readings which they remember, and probably the ones which they like, they would mention that when they come. But if you compare that with somebody who's regularly writing down on a notebook, that also is very good. And if you have a connected system where the glucometer is connected to a app which is coming with all the data is coming to the doctor or to the patient himself, he has an analysis of the data. that makes it very useful in terms of making adjustments in the
Thank you.
dosage.
And
So I think
also-
that is something which is coming up, and it is becoming very popular nowadays with the availability with the costs of glucometers and strips coming down.
And also it's become little more cost effective. You
Yes.
know, Professor Muralidhar Rao, Sangramji will remember, had a very important message to give. He will say, we can only improve what we measure. Remember, Sangramji? He would say,
Yes.
we can only improve what we measure. You know, he was the 65th president of the API. Sir, before coming here, I had a chat with Sangram. I asked him, sir, what questions do I ask? He said, sir, taken from the chat box. Rest of the questions centered around a talk which is full of love for Professor Muralidhar Rao and plus science, plus learning. So his API presidential address was on the diabetes and heart disease, remember. And when he came back with the training from the echocardiography, Vagesh, he was with Antony and Antony JP. And he was very close to him, and there are a lot of echocardiography features. Now, I'll have 3 questions on diabetes and heart. I will start with Rakesh, then go to Vagesh. Rakesh, do you think that the diabetic heart disease can be conquered, can be prevented? So I just yes, no answer because I've got 15 minutes more only. No, not 15, 13 minutes. So how can you prevent and treat diabetic heart disease with the available drugs in the armamentarium?
So I think I would be looking very positive and saying that yes, it can be prevented. I mean, although it is not a very simple answer like that, because there are many aspects to it. But I think with the availability of newer drugs like the SGLT2 inhibitors, the results that they've shown in the CVOT trials and the GLP-1 analogs, Dr. Bansali has alluded to that in his talk. I think they have actually made it made the horizon very positive. I mean, we are all very positive that we can do something in terms of primary prevention also of our cardiovascular disease. And that is something that is what I would like to say in the few minutes.
Absolutely correct. Absolutely correct. I think, Vagesh, for you left only one thing.
Yes, sir.
How would you place early combination therapy? And I'll be provocative to ask you early combination therapy of metformin, maybe pioglitazone, which not only Difronjo, but Anil Bansali gave a new life in his talk today. Anil, thank you. Anil, where are you? Anil, your face is dark. Why you put a light in front of your face? Anil, you gave a new life today because I think we are insulin resistant. So, so that's why you are given new life. I like it. So metformin, pioglitazone, and Rakesh beautifully spoke about the SGLT2 and also alluded to oral semaglutide, both Rakesh and his speaker Anil. So, I mean, would you like to bring in these combinations early in type 2 diabetes?
Yes, sir. I think we should hit hard right from the beginning, because if you see, the functionality of the beta cell has lost close to 78% when you're diagnosed diabetes. That's 6.5%. And also we are waiting it to cross 7, then introduce one agent by other agent, doesn't serve the purpose and doesn't address the pathophysiology. In fact, I feel the dream combination molecules to prevent the complication, also to keep the glucose under very good control, will be an metformin, GLP-1 or DPP-4 based on the patient's acceptability and the affordability, and SGLT2 inhibitors, and pioglitazone in the small dosage. In fact, pioglitazone is a wonderful drug, but only thing, it has to be handled very carefully. In fact, we are using pioglitazone even though it was in a suspicious period in 2012, but it's a very beautiful molecule, has to be handled carefully, then it gives excellent results.
Absolutely, very fabulous answer. I'll just change the gear to last question on cardiovascular disease, not the last for the evening. Now, I will ask, maybe I'll ask this time, Anil. Anil, I'm provocative. What's your take on the diabetic cardiomyopathy?
Diabetes?
I want only 2 cents, cardiomyopathy, primary specific heart muscle disease, without coronary, without any other heart disease, a primary heart muscle disease diabetes.
Okay. I think with the greater facilities, with the greater data available after the SGLT2 inhibitors, and the increasing awareness about the heart failure in patients with type 2 diabetes have really changed the whole scenario. And now the data says that even the 50% of patients with diabetes, they do have some kind of, whether it is a preserved or whether it is a reduced ejection fraction, they do have a heart failure during their lifetime. So heart failure is not uncommon in diabetes. That's one. Secondly, your SGLT2 inhibitors really have a change of scenario, as I mentioned very clearly, that they do have a beneficial effects on cardiac myocytes. So the hospitalization for a heart failure was reduced almost by 1/3. So that was one of the very interesting finding. And remember, SGLT2 inhibitors are the only drug which have shown to reduce the mortality in type 2 diabetes. So you see, there is no other drug which has been really shown to reduce the mortality. Only SGLT2 inhibitors have shown a mortality benefit. So seeing all these benefits, that heart disease, heart failure is not uncommon, one. Secondly, mortality benefits with this class of drug. So therefore, the SGLT2 inhibitors are, I think they are the must for the patients with diabetes and heart failure. And that's why you also mentioned about that why the combination therapy should not be initiated, like we had in a verified trial where the data were very, very illuminating about the your vildagliptin and metformin at a hemoglobin A1C even of a 6.8. So even you can use this class of a drug as being the non-secretagogue. And so you can use this class of a drug even at a lower hemoglobin A1C as a combination therapy and give the cardiovascular benefits to each patient with type 2 diabetes. We do understand hospitalization for a heart failure. It is for both primary and secondary prevention. For a 3-point MACE, the more beneficial effect already for as a secondary prevention, not for as a primary prevention. So I think this class of a drug, and now recently data also shows the use of a prior use of a SGLT2 inhibitors increases the efficacy of both DPP4 inhibitors as well as sulfonylureas. So I think the metformin and SGLT2 inhibitors combination, even at a hemoglobin A1C of 7, can be very useful, provide the cardiovascular protection benefits to the patients even from beginning, rather than adding after metformin, say after 3 months failure or 4 months failure till you achieve the targets.
Thank you. I think very important message that we have given in this meeting today, that early combinations are useful, and we have given that that we can use pioglitazone in a less dose, maybe 7.5, maybe 15. People abroad have used 30 milligram doses. I'm told by many people, Paresh Dandona and others, Vagesh, Murli, Vagesh, Anil, and Rakesh, and my dear friends, that they usually start 3 or 4 drug combination, and they said they have not seen many complications. Am I correct? It's all insurance paid, but they have added GLP-1. I remember one of the articles of Professor Muralidhar Rao. That's what Sangramji told me, that you think about him and think what comes to your mind. That was a 2003 article, Sangramji. I think my dear friend, the ICP Dean is also here, Jyoti, and the paper wrote about essential hypertension. You know, he was also president, sir, you remember, Sangramji, of the Hypertension Society of India. Yeah. And he wrote about hypertension and diabetes and wrote about the pathogenesis of essential hypertension. I will not go into the details, but I would like to know that what is the, you know, we always say the treating hypertension in diabetics more important than treating blood sugar. Now, Rakesh, clear-cut message to the audience who have joined here in large numbers. Diabetes and hypertension, when they occur together, how will you treat? 1, 2, 3, 4.
Yeah, so I think very clear, message that has to go out is that you should always remember about hypertension, never forget about hypertension while managing diabetes, because that is something which coexists with diabetes very often. It may even anticipate the development of diabetes itself, because both of them have a common soil of origin, insulin resistance, as Dr. Bhansali was highlighting that in his talk, and he was telling us about that. And so insulin resistance is a very important common soil for both hypertension and diabetes to develop, and so we should never forget about hypertension while managing diabetes. And as Professor Das has said, that even the UKPDS study showed us that managing hypertension gives earlier results, earlier benefits as compared to the glycemic management. So we should definitely take the advantage of that, manage the hypertension, identify hypertension, manage it effectively, because that's much more easier to manage hypertension. I would say that, you know, it's much more easier managing hypertension than the diabetes, and the results are faster. So I think you should never forget about it.
I just wrote an editorial for Meds yesterday. It was a paper which was published. It was a abstract presented in the what's some meeting in Barcelona was going on, cardiology meeting. ESC meeting.
ESC.
Sir, I was not there, but I saw the abstract. They sent it to me, and you know, they have said that taking antihypertensive drugs in the morning or evening, both are beneficial. There is a paper that's taking in the evening is more beneficial, Anil, because that takes care of the nocturnal non-deep loss. So they said, but in diabetics, taking both in morning and evening are equally useful. So I would like to know from Vagesh, what are your messages for the people who have joined? What drugs to use, in what doses to use, what is your ideal goal of blood pressure in diabetics, and do you believe in nocturnal non-dipping?
There is definitely an belief in non-dippers because that's an earliest changes what you see in the 24 hours BP profile in the patients who are prone for the hypertension development. That's why the giving a single dose giving in the night concept came and also showed some results in few papers. Then coming to the use of the drugs, if there is no microvascular damage in the form of albumin excretion or not, I think all drugs are fine, whether it's an ACE, ARB, or even a CCBs are fine to use for a hypertension in patients with diabetes. But if there is an evidence
here, Vagesh, there is a saying. Absolutely, it is from Dr. Bakrish. Sangram Bakrish once told me, you bring down blood pressure. It does not matter what drug you use. He said, by hook or by crook, or by hook and crook, you bring down the blood pressure in diabetics. That is important. I think Vagesh is inspired by that talk of Bakrish.
So one point I would like to say,
Yes.
you were mentioning about the difference between early morning and night administration of the dose. So I would say that earlier we used to see that difference, but now we are using the long-acting drugs, all of them, all the categories we have got more than 24 hours action, whatever drugs we are using now. So those probably don't make so much difference as earlier drugs used to make. When you used to use a short-acting ARB like losartan, it made a difference whether we give it in the morning or the night. Whereas now with telmisartan, which has more than 24 hours action, probably doesn't make that much difference, sir.
And when it comes to there is an evidence of albuminuria, that's end organ damage. I think beneficial effect of a AC and a ARB well proven in type 2 diabetic patient and the AC inhibitors in a type 1 diabetes. And the dosage of the ARB is not limited by our textbook. In fact, I have seen the references of Dr. K.S. Mani from famous nephrologist from Chennai, even up to 160 milligrams of telmisartan. He tells only the limitation is a potassium, not even the creatinine when there is a patient has got. So the goal is important, not the means. I think same thing is put in the different words.
Thank you. Thank you, Vagesh. The last two questions, Sangramji, are from the question box. I'm very happy, sir. People have responded with a lot of questions from Dr. Nina Sablok. She wants to know, let us know blood glucose monitoring without needle prick, like a gluco watch, or the ICMR wanted to develop some instrument which can do the blood sugar measurements without a prick, either from the sweat or from reading sublingual. What is the status? We'll like anybody to answer it, Vagesh and Rakesh. And but a single sentence answer, because we have to hand over to forum to Dr. Sangram.
We are still waiting for a good device like that.
Yeah,
all the devices have limitations.
Lot of money. When Ghulam Nabi Azad was there, I was the additional DG. I was also involved with the product. We have developed some instrument which is undergoing evaluations, Rakesh, in the NIB, National Institute of Biologicals in Delhi, where one instrument developed showing some promise, non-invasive blood glucose, but it is not in final stage. Fantastic answer. And cost and the beat appliance, madam, Dr. Nina Sablok, madam, the cost will be not much and there'll be no recurrent cost, but we have to wait. Doctor, we will give you the answer in another few months' time, because that instrument has been undergoing final evaluation. It has showed some promise. The final question is on a very important thing. What is your opinion on renaming NASH, non-alcoholic fatty liver disease, to metabolic associated fatty liver disease and metabolic dysfunction associated fatty liver disease? And what is the impact of this renaming on diabetes?
Very appropriate, sir. I think I would I'm very happy that this renaming is done because of two reasons. One is that it has a lot of implications on diabetes. From pre-diabetes to diabetes conversion is decided by the presence of fatty liver. If you look at cardiovascular disease among diabetics, it's decided by the presence of fatty liver, and the progression of various complications of diabetes is correlating with fatty liver. And more important than that, what we can see is that of all the medications that have been tried till now for managing fatty liver disease, it is the anti-diabetic medications which have shown the best results, with the SGLT2 inhibitors, the GLP-1 analogs recently, and I think pioglitazone. Whereas if you look at all the other therapies, they have been very skeptical. I mean, vitamin E or any of the other therapies. There was some other agent which came in with a lot of fanfare, but I don't think it made any impact. So I'm
Absolutely
not able
correct.
to recollect the name. But
Yeah,
I think it's only the
obexopolic
anti-diabetic medications which have made an impact.
you are referring to obexopolic acid. Obexopolic
Ah,
acid.
obitocolic acid.
Yeah,
Obitocolic
but
acid.
all these drugs have not stood the test of time. And pioglitazone is the officially approved drug today, which is anti-diabetic drug. I think calling it metabolic associated, metabolic dysfunction associated fatty liver disease makes this sphere wider and also give your wider thinking. The death of these cases is because of the cardiovascular disease. All of you know that. So it becomes wider thing. Dear friends, every good thing has to end. I'm extremely grateful to the MESART and to my dear friends, my senior Professor Sankar, whom I do my pranam, to Muruganathan and to everybody, Al-Seti. I mean, we are so close. I remember going to Gulbarga year after year. I had a very nice hospitality in Professor Murli's house. Madam prepared hot pakoras. I remember like yesterday. It was so great, and I'm in love with Gulbarga and Professor M.S. Rao and his family. And I think with this, my job is to thank MESART. You have done it. Everybody does not do it this way. You have tried to keep in memory ever one of your colleagues who was worth his name, worth his work. Am I correct? And who loved everybody. And your tenacity of purpose year after year will not go in vain. It will be a trendsetter. Jyotirmay Pal is here, who is a very person in the API today. Rakesh is here. They will follow various. If you do not name and honor our own fellows, who will do it? And thank you very much for inviting a talent like Dr. Anil. Anil has given 3 orations last year where I was chairing. Anil, do you remember? Anil, thank you very much, the professors for the wonderful oration, and many sincere thanks to Vagish and Rakesh. Your panel discussion questions, the people who put the questions, we have tried to do whatever best possible. Over to Sangram Biradarji for the taking it forward. Thank you.
Thank you, sir. It was a wonderful moderation. No other person better than you can do such a grateful job. Now it's time for our closing remarks by Dr. Shivraj Alshetty for vote of thanks. Over to Dr. Shivraj Alshetty.
Good evening, and happy Ganesh Chaturthi for all faculties and participants. Coming to the MESART, we started this trust to encourage the medical service activities as well as continuing medical education activities in Gulbarga and around. And we have been conducting regularly oration in memory of Muralidhar Rao. Another good oration is being organized on rheumatology, sponsored Dr. G. Narasimlu. And this will continue, and much more activities we have planned to do.
Very good.
Coming to today's talk, Dr. Anil Bhansali was excellent for his talk. Yes, talk on the paradox of diabetes, and it was very informative information to all us. And I thank Dr. A.K. Das, sir, who is very close friend of us and very frequently visiting us, and recognize us wherever we go. And for his excellent moderation of this panel discussion, excellent participation by Dr. Vagesh Iyer and Rakesh Iyer and also Anil sir. I also thank Dr. P.S. Shankar and Muruganathan, who are always our patrons in any of these activities, and they will be helping hand to us. And also thank Dr. Jyotirmay Pal, Dean-elect ICP, for his inaugural address and his presence. And I thank Dr. Anthony, Muralidhar Rao, and Dr. P.S. Shankar. We were associated in the medical college for almost 3 decades. I do not forget their company and their discussion and their encouragement to the youngers. I also thank Dr. K. Govinda Babu, who is the chairman of Karnataka State API chapter, and I thank Dr. Anand Muralidhar Rao, who was our student also, and his family members will always make their presence on this oration. With this, and also thank all the participants for their good interaction and their participation. We see that almost 50 to more than 50 of the participants at the different places. With this, I thank everyone making this oration very success. Thank you, one and all.
Thank you.
Sir. Good night.
I
Thank
think
you, sir.
this
Thank you,
will
one and
close
all.
the
Yes.
Thank you.
ceremony.
Thank you very
Thank
much.
you.
Anil,
Thank you. Thank you.
Thank
Thank
very
you,
much,
Dr.
Akshay
Thanks a
ji.
lot.
Thank you, sir. Thank you, sir.
Thank you.
Rakesh, thank you.
Thank you,
very
sir. Pleasure, sir.
Thank you.
Always.
Thank you, Rakesh.
Thank
Anil,
you, sir.
thank you. You again. Bye. Bye, sir. Bye.
Bye.
I will leave now, sir. Can I leave now, sir?
Yes, sir.